Hey everyone, I hope you and your families are safe through these crazy times. For the foreseeable future, the clinical work is going to be light since elective cases aren't going on. But I don't see any reason why we can't continue on with the academic side of things. I would hope that you guys would still do the weekly assigned readings. And for my part, I will post a PowerPoint to YouTube with my thoughts on the week's topic. We will spend most of this topic talking about colonic volvuluses. As a starting point, the basic definition of a volvulus is a twist of an organ around its vascular pedicle. Of course, this is what we don't want to see when we operate on a patient for a volvulus. A volvulus is a closed loop obstruction, and as such, vascular compromise can occur very quickly. Take a crack at this question, and we'll go over the answers in just a moment. Well, the correct answer is C. Volvulus is clearly associated with a high residue diet. In the U.S., volvulus is a very uncommon cause of colon obstruction. Cancer and diverticular disease are way more common. In other countries, especially Africa, volvulus is quite common and accounts for about 50% of colon obstructions. There seems to be an inverse relationship between the incidence of colon cancer and the incidence of volvulus. Colon cancer is common in the U.S., but volvulus is not. In Africa, it's the reverse. And one linkage between these findings may well be in the type of diet. Most of the patients that we will see with a sigmoid volvulus do have an underlying neurologic or psychiatric disorder. They may be institutionalized, or they may be on various psychotropic medicines. One common theme for these patients is chronic constipation. D is important. This is the anatomic reason that a sigmoid volvulus occurs. This is an acquired condition. Patients have a very redundant sigmoid colon, and the mesentery is very narrow-based, allowing for the twist. This picture shows very well the anatomic prerequisites for a sigmoid volvulus. We have a very redundant sigmoid colon and a narrow mesentery. This sets up a situation where it's easy to twist around this narrow pedicle, setting up a closed loop obstruction with vascular compromise. Most of these patients will present with a bowel obstruction type picture. That is a colon obstruction type picture. They'll have cramping abdominal pain, and they will be massively distended. Oftentimes, the first study obtained is a plain film of the abdomen. The classic finding is the so-called bent inner tube sign, which shows the dilated colon pointing up towards the right upper quadrant. Unfortunately, this classic finding is only seen in about 60% of the cases. Other ominous findings on KV would be pneumatosis, which would suggest impending bowel perforation. Most patients who present to an emergency room with massive abdominal distension are going to get a CT scan. This test is extremely accurate in diagnosing a sigmoid volvulus. It is also useful, of course, for ruling out other reasons for obstruction, like a mass lesion. The characteristic CT finding is the so-called Whirl Sign, which represents the vascular pedicle that's been twisted. Contrast studies are not indicated in the acute setting because of the risk of perforation. However, there are some patients who have a more chronic type picture, in which case a lower GI may have some value. The classic finding will show the barium ending sharply at the point of torsion, the so-called bird beak sign, as seen here. All right, let's talk about a couple of clinical scenarios. The first one will be a patient with a diagnosed sigmoid volvulus, probably diagnosed in the emergency room by a CT scan. Clinically, they have no peritonitis. So what I would suggest you do is maybe pause the video and work through these questions on your own. This is really the crux of the matter, and I think everyone should feel comfortable about how to approach this patient. All right, what is the first thing to do in a patient with sigmoid volvulus and no peritonitis? Probably the first thing to do is to try to decompress this volvulus. This can generally be done right there in the emergency room with a rigid proctoscope. A little pro tip, I suggest you wear a gown, gloves, mask, face protection, because when you untwist this, you'll be hit with a hurricane-like blast. But a rigid scope will generally be able to reach the point of obstruction, and as it passes through, it will untwist the volvulus. Once the volvulus is untwisted, you need to leave some kind of tube in place. In my experience, a rectal tube is never available in the emergency room, but what usually is available is a chest tube. So you could put a small, maybe a 24 French chest tube in that serves to help keep it decompressed and also helps to prevent retwisting. Another pro tip, be sure you suture this tube in place. If you don't, it for certain will fall out before the patient ever makes it to the floor. All right, well, after you've decompressed this patient, we have to make a decision on surgery. First of all, does this patient need an operation? And the answer is yes. Why? Because these patients will revolvulize with a very high degree of certainty. So they do need surgery, and they should have it done this admission. If you send the patient back to the nursing home, the odds of you seeing that patient back in your office are very, very low. So what do you do to prepare this patient for surgery? Well, we for sure want to bowel prep this patient. The other thing that would be nice is a colonoscopy. Why do we want that? Well, patients like this are older. They could certainly have a concomitant cancer somewhere up at the splenic flexure, the hepatic flexure, and it would be embarrassing to do a colon resection and then be missing an obvious cancer. So I would say this patient needs to be bowel prepped. The patient should have a colonoscopy and then should undergo an operation this admission. Well, what operation do you want to do? There's a couple of choices, but only one is reasonable. You need to resect this colon. The redundant colon needs to be removed. Theoretically, excuse me, you could consider doing a sigmoidopexy, but this will universally fail. The anatomic problem here is a redundant colon with a narrow mesentery, and so the only thing that will provide long-term cure is to resect this anatomic problem. A sigmoidopexy has the theoretical value of avoiding an anastomosis in an often debilitated patient, but it just doesn't work, and recurrence is extremely high. So simply don't do this. This is a nice X-ray showing successful endoscopic decompression with a rectal tube nicely placed. So this slide just sums up what we're trying to accomplish. The purpose of endoscopic decompression is to convert an emergency case into sort of a semi-urgent or semi-elective situation. This allows us to bowel prep the patient and correct any other medical issues. During that admission, this patient should undergo a sigmoid resection with primary anastomosis. This could be done open, laparoscopically, or robotically, depending on your own particular skill set. And again, don't be tempted to do a sigmoidopexy. This has no role in this disease. Okay, let's talk about another situation. This is the patient who presents with a sigmoid volvulus who does have obvious peritonitis. Let's figure out what we want to do with this patient. Again, pause the video for a few seconds, get your thoughts together, and then we'll go through this. Okay, first of all, is there any role for doing endoscopic decompression in this type of patient? It's probably obvious that the answer to this is no. The reason to decompress the patient is to convert an emergency situation into a semi-urgent situation. In this case, with peritonitis, there's no reason to wait. This patient needs to be in the operating room. So no endoscopy. At the time of operation, what are you going to do? In the vast majority of cases, you're going to do a Hartmann's procedure. Resect the dead colon, bring up an end colostomy, leaving either a Hartmann's pouch, usually, or once in a while, if you have a longer segment, a mucus fistula. You're unlikely to have a situation where you'll be tempted to do a primary anastomosis, since these patients generally are older, sicker, hemodynamically unstable in this situation. But I suppose if you had that unicorn type patient, there might be a once in a career type occasion to do a primary anastomosis. But at the end of the day, the Hartmann's procedure is going to be your go-to operation for this situation. Okay, let's shift gears here and talk about cecal volvulus. This is even rarer than a sigmoid volvulus. In fact, a cecal volvulus is only accounts for about 20 to 30% of all colonic volvuluses. Again, this is certainly what we don't want to see. Cecal volvulus, just like sigmoid volvulus, is a closed loop obstruction, and so ischemia and frank gangrene develop quite quickly. The etiology of a cecal volvulus is very different than that of a sigmoid volvulus. The sigmoid volvulus is an acquired condition related to chronic constipation with lengthening of the colon and a narrowed mesentery. The cecal volvulus could be thought of as a congenital problem. It really is related and caused by failure of fixation of the cecum and ascending colon to the retroperitoneum and lateral abdominal wall. So what it leaves you with is a very floppy and highly mobile entire right colon. So in some ways, the term cecal volvulus is a misnomer. The problem is really related to the entire ascending colon and even the terminal ileum. There are two distinct ways that the cecum can volvulize. By far the most common is via an axial rotation or axial twist. In this situation, the highly mobile ascending colon and terminal ileum twist usually in a clockwise fashion around its mesentery, setting up a closed loop obstruction. Since the terminal ileum is involved, these patients can sometimes present with the symptoms of a small bowel obstruction. The second and much less common way that the cecum can volvulize is the so-called anterior folding way, or sometimes referred to as a cecal bascule. In this case, you have a cephalad fold of the cecum across the ascending colon. The classic KUB finding is referred to as a coffee bean cecum. This shows the cecum pointing up towards the left upper quadrant. The CT scan findings for a cecal volvulus are pretty characteristic. If they have axial torsion, the Whirl sign is diagnostic just as it is in a sigmoid volvulus. If the patient has a cecal bascule, you'll see the cecum folding upwards and there'll be an obstruction, but there's no axial twist. On the scan of the cecal bascule here, you can see the dilated loops of small bowel as well, characteristic of the small bowel obstruction that goes along with these patients. A contrast study would rarely be done today, but if it were performed, just like with a sigmoid volvulus, the bird beak sign is diagnostic of a volvulus. Okay, well, let's talk about what to do with a patient with a cecal volvulus. The first situation would be the patient who presents with a diagnosis, but no peritonitis on clinical exam. So again, why don't you pause the video for a few seconds, look at these questions, figure out what you want to do, and then we'll get back at it and we'll work through some of these and I'll give you my thoughts. Okay, well, the first thing is there's some significant treatment differences between a cecal volvulus and a sigmoid volvulus. This makes some sense since they, one is an acquired problem and one is more a congenital problem. First, is there any role for endoscopic decompression in someone with a cecal volvulus? And the answer in this case is a clear no. It's not effective, unlike in the patient with the sigmoid volvulus where it was highly effective, and it only delays the inevitable surgery. So we don't do colonoscopies on these patients to try to untwist it. All right, since they need an operation, and they really need an operation at the time of diagnosis, this is not the kind of case that you want to admit and then put it on the next day after your elective surgery cases are done. By that time, you're likely to have a dead colon. In most cases, the operation that you're going to want to do, and that will solve your problem, is a right hemicolectomy, generally with a primary anastomosis. I think this is your go-to or your plan A sort of procedure. There are some other operations that have been described and have been done with not nearly as much success. One operation is a cecopexy. Well, why might that operation be even considered here? Well, the reason why it's considered is because these patients have a problem with abnormal fixation of the ascending colon. So why not just secure this colon back to the abdominal wall where it belongs? That seems to make perfectly good sense. You're trying to correct the underlying anatomic problem, which is failure of fixation. And although it makes a certain amount of theoretical sense, it just doesn't work in practice. These colons are very distended. They have the tissue, they have the consistency of tissue paper. And when you try to suture this distended, very thin wall colon to the abdominal wall and start tying these knots down, invariably it tears. And so it's an idea that sounds good, but just clinically doesn't work in practice. Another consideration is a cecostomy tube, where you fix the cecum to the abdominal wall via this tube. This is another operation that makes a certain amount of sense. However, this operation is fraught with problems. This tube is prone to leaking. When you pull it out, sometimes you get a fecal fistula. So in general, it really probably should almost never be done. Your go-to operation is a right colon resection with primary anastomosis. These other operations like cecopexy and cecostomy tube are, although they may make a certain amount of sense just talking about them, practically they just aren't very useful to you. Well, what are we going to do with the patient with a cecal volvulus who presents with obvious peritonitis or who at the time of surgery has obvious dead bowel? I suppose the first consideration to make is when you get in there and the bowel is clearly dead, should you detorse this volvulus? Some argue that you shouldn't, that untwisting it will release the evil humors and that you'll get a reperfusion injury like you might see after reperfusing an ischemic leg. So if the bowel is clearly dead, it makes some amount of sense to not untwist this volvulus. The historical operation for this has always been a resection of the dead bowel, generally a right colon, with an end ileostomy and a mucus fistula. Of course, management of this going forward is difficult. Ileostomies are hard to manage, and many of these are never reversed. Over time, I would say most of these patients, if they're at all stable, will undergo a right colon resection with a primary anastomosis. Okay, well, let's sum up the topic of colonic volvulus by looking at some of the similarities between a sigmoid volvulus and a cecal volvulus. The first is which one of these is a congenital problem, and that's clearly the cecal volvulus. It's a failure of fixation. A sigmoid volvulus is an acquired problem. In fact, a sigmoid volvulus is associated with chronic constipation. Which of these is associated with abdominal distension? And I think the answer to that is clearly both. Just on physical exam, you're not going to be able to distinguish between either of these entities. The sigmoid volvulus is associated with older patients. Do either of these conditions require contrast studies? I don't think so, not anymore. CT scans are so good. They are usually our go-to imaging. Endoscopic decompression is useful only for sigmoid volvulus. It's really contraindicated for cecal volvulus. And a cecal volvulus often will present with small bowel distension, similar to what we see in a small bowel obstruction. Okay, let's move on to the next topic for today. This is pseudo-obstruction of the colon, or more commonly called Ogilvie syndrome. Dr. Ogilvie gets credit for this disease because he published a case report of two patients who had malignant infiltration of the celiac plexus, and they also had they both had chronically dilated colons. The exact etiology of Ogilvie syndrome is unknown. It's hypothesized that sympathetic overactivity overwhelms parasympathetic activity. Sympathetic activity decreases bowel motility while parasympathetic activity increases it. Why this may occur in many patients is clearly not worked out. The cecum and right colon are always involved in this disease, although often it is pancolonic as well. The real fundamental problem here is that as the colon gets ever more large, the wall tension increases. and ultimately this leads to a risk of perforation. There are two sort of independent risks for perforation. One is a cecal diameter greater than 10 centimeters, and the other is dilatation of the colon for greater than 6 days. As surgeons, we're often called to see a patient on the floor with abdominal distension. Someone with suspected Ogilvie syndrome could also have a volvulus or a malignant obstruction. So our first task is usually to rule out obstructive causes, often with imaging. Pseudo-obstruction almost always occurs in hospitalized patients, and it's particularly common after orthopedic procedures such as hip fracture repairs. It can also be seen after non-operative trauma management. Narcotic use and electrolyte abnormalities are also an extremely common occurrence in these patients. A plain abdominal film will often show massive colonic distension. Unfortunately, this is non-specific. This is perfectly consistent with a malignant obstruction as well, so further imaging is usually required. A Gastrografin Enema is a useful study for ruling out malignant obstruction, as is, of course, a CT scan. For those of you who are flowchart fans, here's one that's pretty reasonable. Our first job is to rule out a mechanical obstruction, and once we've done that, then we will try to manage this patient conservatively. We'll talk about that in just a second. If that doesn't work, then there's drugs and other maneuvers to try to fix this problem. Ultimately, what we're trying to prevent is perforation of the colon. Fortunately, most patients with pseudo-obstruction get better with simple basic maneuvers. Patients are generally very distended and quite uncomfortable, and they're often bedridden, so making them NPO and putting an NG tube in can be quite useful to reduce aspiration risk. Electrolyte disorders are common, especially hypokalemia and hypomagnesemia, and these need to be fixed. All offending drugs should be discontinued if any way possible. Narcotics should be switched over to Toradol or other non-narcotic pain medicines. If the patient can get out of bed, that's ideal. And the one thing to avoid is laxatives. It seems somewhat counterintuitive, but for patients with pseudo-obstruction, laxatives seem to make the problem worse, not better. If a patient does not respond to conservative management after several days, then we need to escalate what to do. Neostigmine is the first thing to try. It's been approved for treatment of pseudo-obstruction of the colon. It's a drug that increases parasympathetic activity, so it's going to increase colonic motility. Its major problem is bradycardia, so it needs to be given in a monitored setting, and atropine must be quickly available. It can also cause very severe abdominal cramping. It works quite quickly as well. If our patient cannot tolerate neostigmine or has some contraindication to it, then colonoscopic decompression can be considered. There are several issues with this. It sometimes requires several attempts, and it comes with a pretty high perforation rate of 3%. If nothing has worked so far, then a percutaneous cecostomy tube could be considered. This tube has many problems associated with it, just like it did with a cecal volvulus, leakage around the tube, peritonitis, wound infections, fecal fistulas once it's removed. So all in all, this is only done in patients who just are poor operative candidates, and this is a bailout type procedure. Well, who would ever need surgery for Ogilvie syndrome? Again, pause this for a few seconds and take a look at these questions, and then we'll go through them. So who would you ever consider operating on for these problems? Well, there are several indications. One would be the very rare patient where nothing else worked. Conservative measures didn't work. Neostigmine didn't work or couldn't be used. Colonoscopy didn't work. Then surgery is indicated for this patient. Of course, the other indication is the emergent indication, someone who develops peritonitis or frank perforation. So what operation would you do? What would you do for the patient who flunked all other management? And of course, the reason to go to surgery is that if you keep waiting, eventually this colon is going to perforate. So what would be the operation to do in someone who hasn't perforated but has flunked all other measures? Probably the most straightforward and easy thing to do would be a loop colostomy, either a transverse loop or possibly a sigmoid loop colostomy. This should decompress the colon proximally and distally. Another consideration would be to divide the colon and bring it up as a so-called double barrel colostomy. But I think a loop colostomy is relatively simple in this type situation. In the emergent situation, the patient who has peritonitis or perforation, well, of course, they're going to need a resection of that segment. You'll never put these patients back together primarily. That's just going to be contraindicated. So this will be a Hartmann's procedure with end colostomy and either a mucus fistula or a long Hartmann's type pouch. Well, wasn't that fun? We'll forge ahead and continue with our schedule. So next week, we'll talk about C. diff colitis and ischemic colitis, and I'll try to get this PowerPoint up on YouTube, hopefully by Monday evening.